Supraspinatus is a very complex structure that's composed of 5 layers. Layer 1 includes the superficial fibers of the coracohumeral ligament. Layer 2 is a layer of closely packed parallel fibers of collagen. Layer 3 is similar to layer 2 but with less uniform fibers. Layer 4 is the deep fibers of the coracohumeral ligament, also known as the rotator cable. And the 5th layer is formed by the joint capsule itself. Now, the biggest dilemma faced by sonographers when it comes to supraspinatus is in the classification of tendon tears. And this can be as difficult as the tendon is complex. Generally speaking, classifying tears is based off of this image in long. And if the tear contacts the articular surface, it is an articular surface tear. If the tear contacts the bursal surface, it is a bursal surface tear. If the tear does not contact the articular or bursal surface, it's an intrasubstance tear. And if the tear communicates between the articular and bursal surfaces, it is a full thickness tear. Now, if this full thickness tear extends the entire width of the tendon, then it is a full thickness complete tear. And if it does not extend the entire width, then it is a full thickness incomplete tear. But even with this clarity on the matter, it can still be extremely difficult to classify tears. Take this case for an example. Here we can see off of our 2 B-mode images a high-grade partial thickness tear of supraspinatus, but it's only in the cine loop do we appreciate that this tear contacts the articular surface, and as such we have a high-grade delaminating partial thickness articular surface tear of supraspinatus. Now, that term delamination is a term used frequently to describe tendon tears. Essentially, this is where the tendon fibers fail along its longitudinal axis. So in this example, this represents the delaminating aspect of this partial thickness articular surface tear. The other difficult thing with supraspinatus is understanding the paradox behind this image here. This is a beautiful image. Here we can appreciate the biceps, the multi-layered supraspinatus tendon, as well as the articular cartilage of the shoulder in short axis. But as beautiful as this image is, it is in equal measure completely useless. Because we can see the articular cartilage, that means that this transverse image of the tendon is obtained through this cut of the tendon, that is, proximal to its enthesis. And as such, the enthesis-based tears, which are so common, will not be demonstrated in this transverse image. We need to continue to scan distally in transverse all the way to its enthesis. So don't be fooled by the beauty of an image. Ensure that the beauty of the image lies in its diagnostic value. Now, here is a common finding. We see a small linear echogenic focus at the insertion, and this is often incorrectly diagnosed as calcific tendinopathy, but it's not. This is simply some scarring and granulation along that tendon. Similarly, this is often mistaken for acute calcification. Now, the clinical presentation will differentiate this, but this is simply granulation or scar tissue in the context of a full thickness supra tear. Now, I've included infraspinatus in this section also, because you cannot assess supraspinatus without also assessing infraspinatus. The 2 tendons interdigitate, they cross over. It is a confluent cuff. Here you can see that the distance between the biceps and the anterior aspect of infraspinatus, as denoted by the humeral head facets, is just 15 millimeters. So I'll ensure that I scan infra in every position that I scan supra in. The other tip when scanning infraspinatus is simply to scan it with the patient's hand on their lap. In this way, we can easily assess infraspinatus, teres minor, and the posterior joint, and we can easily identify the different bony facets that help to denote and differentiate infraspinatus from supraspinatus. Thanks for listening, guys. Like and subscribe for more content.